Hello and welcome to my Nursing 512 Evidence-Based Project Step 5. There is a current protocol in place in the where I work that the nurses implement when they receive a post-cardiac arrest admission. The PICU participates in a national research called the THAPCA, which stands for Therapeutic Hypothermia After Pediatric Cardiac Arrest. The purpose of the study is to determine whether regulating the body temperature will improve the outcome for children after cardiac arrest. Fever occurs commonly after cardiac arrest and has been associated with a worsened outcome, meaning brain damage or death. Therapeutic hypothermia has been successfully used in adults after cardiac arrest to improve outcomes. It has been studied in newborns with perinatal asphyxia, but not been studied in infants or children after cardiac arrest. It would seem that implementing something into the practice of a major children's hospital that there would be glaring evidence to support the intervention. Therefore, the PICO question was formulated. In pediatric patients, does induced hypothermia reduce brain injury severity after cardiac arrest? When research began for this question, it was quickly apparent that I would have some difficulty finding exact results, as this THAPCA study is still ongoing. Articles were selected for review based on how closely related they were to the question being evaluated. Many articles contain a sample size of adults greater than 18 years of age when the desired age range was less than 18 years. Other articles found were based on neonates post-perinatal asphyxia when the desired population was unrelated to birth asphyxia. The level of evidence of the articles were not strong and mainly consisted of retrospective, observational, or cohort studies. However, there were a few randomized controlled clinical trials, although their sample sizes were greater than 16 years of age, and therefore could not be considered reliable studies related to the practice question. The results of each study were just as unsatisfying as their relation to the question at hand. Most of the results involving pediatric patients were inconclusive, deeming more research is needed, including an independent clinical trial, to gain a deeper understanding of the effects of hypothermia on the pediatric post-cardiac arrest patient. There were too many extraneous factors which placed limitations on each individual study. Limitations included presence of a chronic disease pre-arrest, what caused the cardiac arrest, medications received during resuscitation, and the duration of the non-perfusing heart rhythm, and an inconsistency in how neurobehavioral outcomes were measured. However, the results did give some insight on the possibilities of therapeutic hypothermia and the feasibility of implementing it into practice. The information presented in these articles can lead me toward a suggested practice change, but ultimately, more information is needed to provide a higher quality of evidence. Many of the studies looked at what increased or decreased mortality in pediatric patients. However, the results were conflicting. For example, one study found there was an increased mortality found in pediatric patients who experienced cardiac arrest in the ICU as opposed to those not in the ICU. In another study, researchers found that survival rates 10 days post-event was 42% in outside hospital cohort group compared to 63% in the in-hospital cohort group. Differences between the studies place more limitations, such as the presence of a renal dysfunction prior to cardiac arrest, concurrent epinephrine infusion, number of calcium boluses, and the use of ECMO within 24 hours post-event. Only one study examined possible negative effects experienced with induced hypothermia: hypokalemia, bradycardia, thrombocytopenia, hypotension, and a rebound increase in ICP associated with a rewarming period were all symptoms experienced with induced hypothermia in a randomized controlled trial. The study did conclude that early intervention, mild to moderate hypothermia, improved mortality and functional outcomes after severe traumatic brain injury in patients greater than 16 years of age. Another study also concluded that patients post-cardiac arrest due to ventricular fibrillation had favorable neurological outcomes and decreased mortality after receiving mild therapeutic hypothermia. After reviewing all of the results, it is very apparent that a randomized controlled trial is needed to produce stronger evidence in favor of therapeutic hypothermia in the pediatric patient. However, there is evidence supporting the favor in the adult and neonatal population. Therapeutic hypothermia may be implemented into the practice of pediatricians if careful consideration is given due to the nature of the child's arrest and the possible negative outcomes that can occur during the cooling and rewarming periods. Special attention must also be given to the length of time the patient is cooled for. Recommendations include 24 to 48 hours by THAPCA and the degree to which they are cooled. Recommendations include 32 to 34 degrees Celsius by THAPCA. Due to the lack of hard evidence, implementing this change into practice may be difficult. However, it seems to have already been implemented into the 41 centers across the United States and Canada who are currently participating in the study. A major barrier to implementing this protocol are physicians. Physicians may give some pushback to initiating hypothermia into their practice if they have bias or a personal disbelief of the practice. They are ultimately the ones who are caring for the patient and making the decisions for their care in the post-arrest period. Physicians may also be uneducated in the area of therapeutic hypothermia and be reluctant to initiate it. Other areas which will prevent implementation into practice are areas where hypothermia is not indicated or not studied, such as hypothermia after cardiac arrest during bypass procedures for congenital heart disease pediatric patients. In 2010, a retrospective cohort study was done to determine the feasibility of implementing a hypothermia protocol in pediatric cardiac arrest patients. The study examined 181 patients after cardiac arrest, of which 91% were asphyxial in etiology. Of these patients, 40 of them received therapeutic hypothermia, and 78% of the therapeutic hypothermia survivors were discharged home versus 68% of those patients who received standard therapy. The study concluded that implementing therapeutic hypothermia was feasible. However, a study was needed to determine the efficacy of therapeutic hypothermia in pediatric patients after cardiac arrest. It is very apparent that more studies are needed to truly determine the efficacy of therapeutic hypothermia in the pediatric post-cardiac arrest population. The major national THAPCA study is currently ongoing and estimated to be completed in late of 2015. After results from this study are compiled and reviewed, we can look more deeply into why therapeutic hypothermia works or doesn't work, and what the recommendations should be. It could be anticipated that more research could be done on the side effects related to the cooling and rewarming process, why they happen, and what effects they have on the overall mortality rate and neurobehavioral outcomes. More research should also be completed on patients who have survived to hospital discharge and what their neurologic function they possess. It would be interesting to see a study on patients who receive hypothermia and assess their function at certain time intervals, such as at discharge, 1 year, 3, and then 5 years. Results could be compared to a control group of participants who did not receive hypothermia. Barriers to this study would include the nature of cardiac arrest and age of the participants. Finally, it could be said that we may never fully know how hypothermia affects pediatric patients because their brains are still developing and they are growing and constantly changing. A 1-year-old will indefinitely heal and progress differently than a 15-year-old due to the nature of the human body and their different stages of development. We may conclude that the human brain is such a complex organ and varies so greatly between individuals that more information is needed on the human brain itself before we can fully determine how cardiac arrest affects its neurological function. This class has really helped me to come full circle in understanding how much research really matters to what we do in our everyday practice. Thinking back to how I felt as a research student in undergraduate compared to now is greatly different. I went from learning about how research is conducted to actually being able to apply it to my practice and understanding how it is so important. Throughout the semester, I found myself at work questioning if what I'm doing at the bedside is what is best practice for my patient. I've thought of several areas of my practice and questioned myself as well as other coworkers about the way they carry out a task and if their methods are better than my own. I've listened to my attending physicians reference research studies during their patient rounds and how they implement their own knowledge from research into their practice. I'm a firm believer in evidence-based practice and how it truly makes our nursing practice not just an art but a science. We need to continue to apply research to our practice to give patients the best care that they deserve. Research can also be applied in your own life in so many ways. I've thought about how to apply research in my own life, from the times I administer medications at work to the times I lay my daughter down for her naps, and how variables can change based on your own actions. In conclusion, this class has prevented me from becoming lackadaisical in my own practice. Instead of becoming complacent and just doing things because that's the way we do them, I found myself asking why. That alone is the biggest proponent to keeping research an integral part of any practice.